Rajiv sir and Dr. Santosh sir, and very welcome in this session of this new clinical conversation. So today with us, our three eminent speaker with Dr. Ghanasham sir is our first speaker from Sports Hospital Bhubaneswar, and Dr. Rajiv Jaina sir, senior medical oncologist from NCRI Hospital Kolkata, and Dr. Santosh sir from Star Hospital Hyderabad, the senior consultant medical oncologist. So we are going to start the session. Is technical team with me? Hello. Hello, am I audible?
Rajiv, good evening.
Good evening, sir. Good evening, sir.
କେମିତି ଅଛ?
sir, ଭଲ ଭଲ sir. ଆପଣ ଭଲ ଅଛି?
ରାଜୀବ ସାଙ୍ଗେ ଫାର୍ଷ୍ଟ ଟାଇମ୍ ମୋର ୱେବିନାରରେ ଅଛି ନା ମୁଁ ଆଉ ଆଗରେ ଥିଲି କି ମନେ ନାହିଁ କେବେ।
Very welcome to both of you, sir.
Yes.
On behalf of Bayer Oncology, this is Sagnik, sir. Welcome in this evening.
Oncology ଭାଇ ଭାଇ ଓଡ଼ିଆ ଭାଇ ଭାଇ ବୁଝିଲେ? So
just taking 1 minute.
I am a Bengali in Odisha. He is Odia in Bengal.
Sorry to interrupt, sir. Dr. Santosh Kumar sir is also there.
Yes, yes. Okay, okay. I think technical support team, just checking. Is someone there from technical support?
Yes, sir.
Okay, so we can start.
Yes, sir.
Okay.
So we are starting in 3, 2, 1. Please start, sir. We are live.
So very good evening, and in this session of New Becca Clinical Conversation with us, Dr. Professor Ghanasham Biswas sir, who is a senior medical oncologist from Sparsh Hospital, Bhubaneswar, with his very much rich exposure and experiences in the oncology field. So we are going to welcome sir for this session. Very welcome, sir.
So good evening, all of you, and thank you, Bayer. Thank you, Arnav, for this opportunity. Good evening, Dr. Rajiv and Dr. Santosh. So I hope I am audible and my slides are visible.
Yes, sir. Very much
Yes, sir,
audible
yes,
and
sir.
visible, sir.
So I have the opportunity to present it first because I have another engagement in the second half. So I will be touching upon the ARROWNET evidence. So advancing metastatic hormone sensitive prostate cancer treatment. So we are talking about the drug darolutamide without chemotherapy. Unfortunately, I was a part of this ARROWNET evidence during the COVID time, and I was one of the PI in India. So this is one trial where a good number of Indian patients were there, around 90 plus patients, and from our side there were 5 patients. So I'll allude to in the next subsequent slides also. So this is the disclosure. So at this moment, we have approvals of darolutamide in a 3 setting. So one is a non-metastatic CRPC, which is basically a biochemical relapse. Second is metastatic hormone-sensitive prostate cancer as a triplet therapy with docetaxel and daro. And the third indication, which is we'll be talking on, that is ARROWNET, which is ADT plus darolutamide without chemotherapy. So now, if you see this slide, so as a development, so way back in early 2010, so we started with Charted and Stampede. So when docetaxel was, so we moved from mitoxantrone and steroid to docetaxel as the first systemic therapy with steroid, and ADT has remained as a backbone for prostate cancers in a metastatic setting. Then came the era of ARPI. So on the first drug we know is abiraterone, and then the Latitude and Stampede established abiraterone with ADT as the second modality after docetaxel. So from there on, so we have so many other approvals. So docetaxel and abiraterone, followed by enzalutamide in ARCHES and Enjamet, and then we had Titan, which was represented by apalutamide. So these were era moving from only ADT to chemotherapy and then ARPIs. And then we entered into an era in early 2020 with a triplet, which was never thought of or dreamt of in a prostate cancer setting to improve the significant survival. And triplet slowly became the standard of therapy, at least not for all, but for those patients who can tolerate the treatment, especially younger patients, good performance status and end organs are absolutely fine. So PEACE 1 was in that era the first regimen of combining ADT with abiraterone plus docetaxel plus minus radiotherapy. And the second drug that was in the triplet regimen was similar design with darolutamide. Then we have Aronet and Arasec, so where this was a doublet therapy, so which again I will discuss in the subsequent slide. So despite treatment with ARPI from docetaxel, that is Stampede and Charted, we moved to Latitude and Stampede with abiraterone, but still a good number of patients in a metastatic hormone sensitive will progress to an incurable state, that is metastatic hormone refractory prostate cancers. So if you see the prostate cancer natural history, so if you see, so the upper part is M0, that is non-metastatic, and the lower part is metastatic. So 90% of the patients, 80 to 90% of the patients will present with either a local disease, which is marked as 1, so non-metastatic hormone-sensitive prostate cancer with local disease, and few of them will present with a loco-regional disease. Then the second group will be a metastatic hormone-sensitive prostate cancers when there is an evidence of metastasis, usually or doing a PSMA PET scan or even in the CT scan and bone scan. And we know that most of these patients will have a bone metastasis, skeletal metastasis, which is very common in a prostate cancer because of the obvious reasons. And a good number of patients also will have a visceral disease in the form of either a liver or a lung. So 5 to 25% of the newly prostate cancer diagnosis will present as a de novo metastatic hormone sensitive. Coming to third, so 10 to 20% of this prostate cancer will develop into an HRPC within approximately 5 years of follow-up. And these were ignored few years back. And so this happens in all cancers like prostate and ovary, where there is no evidence of disease clinically or radiologically, but in prostate you will see a PSA rising, in ovary you will see a CA125 rising. So people thought that so this is not a routine phenomenon like ovarian cancer, but these are patients where they will herald into a metastatic HRPCA when the survival becomes compromised. So that's how we entered into an era of treating non-metastatic HRPCA and where darolutamide has established its role. So where you'll have a rising PSA despite serum testosterone less than 40 and radiologically no evidence of disease. So fourth will be the situation. Most of these patients will develop into a metastatic hormone refractory prostate cancers. And the lastly, most men with metastasis progresses to this incurable, that is situation of metastatic hormone refractory prostate cancers within a median of 1 year before the era where we did not treat patients of a non-metastatic HRPC. So if you see this figure, this cartoon on the left-hand side, what are the systemic therapies that's available for treating a prostate cancer? So AR antagonist. So in our earlier days, before abiraterone, it was biclotamide and flutamide. Then came enzalutamide, apalutamide, and now we are talking about darolutamide. If you look below, so much before the systemic therapies like mitochondrion or docetaxel came, so we were treating, so even during my earlier days in DM in 2000, so we were treating patients with ketoconazole. And then we have GnRH analogs in the form of leuprolide and goserelin. and even also we have a triptolin, and in GnRH antagonist we have degarelix and even the oral relugolix. So this is the armamentarium for treating a metastatic hormone sensitive prostate cancer in various capacities. So now today I see a patient of metastatic hormone sensitive prostate cancer. So one option can be a singlet, where we started our journey much years back, ADT alone. So ADT alone today has no role, except you are treating an elderly patients with comorbidities, frail patients. Still the patient party needs some treatment. Then ADT. So I have treated a 92-year-old gentleman quite some time back. So where I knew that I cannot offer this patient either an ARPI or chemotherapy. So I treated this patient with the ADT alone. But today in 2026, so this is almost not done today. So only one of the other patient in a clinic which demands treatment but not fit for any of this ARPI or chemotherapy. So moving from singlet to moving from doublet. So ADT plus docetaxel, which came from the started, and then moved to abiraterone, then having an enzalutamide, then apalutamide and darolutamide. So today, if we are not giving singlet, if we are offering doublet, so we have one chemotherapy, docetaxel, and there are 4 hormonal agents, ARPIs, abiraterone, enzalutamide, apalutamide and darolutamide. So again, in 2026, again, ADT plus docetaxel has no much role. So now we are left with abiraterone, enzalutamide, apalutamide, and darolutamide. So moving from having a 5, so we have stopped using ADT plus docetaxel, which was the first approval in this setting. Then we are talking about triplet. So ADT plus docetaxel and abiraterone plus minus radiotherapy from the PEACE-1 trial. And then the other indications for darolutamide was a docetaxel plus darolutamide. So this is a triplet. So ideal patient in a metastatic hormone sensitive prostate cancer who comes to you today with all good performance status, cardiac functions are fine, then they should be offered triplet so as to gain the maximum survival. So now the prostate cancer, there is a paradigm shift in treatment. As I said, so moving from ketoconazole to singlet to doublet and triplet. So ADT plus docetaxel, which was the first approvals after the era of mitochondrial steroid. So these came from Chartered and Stampede. Then we entered into a doublet of Latitude and Stampede, abiraterone. Apalutamide came from Titan, Arches and Enzyme showed us the benefit of enzalutamide with ADT, and then Arasec and the Aronate were the darolutamide. And as I said, the triplet was the PEACE-1 with abiraterone and Arasens was the darolutamide. So if you look back 2023, when I presented on this subject in another forum of Bayer only, so if you see the 2023, so NCCN guidelines shows what are the systemic therapy for a hormone sensitive prostate cancer. M0, so we are talking about M1, which is highlighted. So preferred regimen with ADT was abiraterone, apalutamide and enzalutamide. So category 1. So you can see, so there is no darolutamide in that setting with ADT. And if you see with triplet, ADT with docetaxel and abiraterone from PEACE-1 and darolutamide from Arasens was already there. So this was in 2023. The preferred regimens were with abiraterone, with apalutamide, with enzalutamide. So no scope of darolutamide then in 2023. And if combining with chemotherapy, then abiraterone and darolutamide is there. But 2023 to 26, so there is a twist in the tail today while treating metastatic hormone sensitive prostate cancer. So what has changed from 23 to 26? Now you are including whether this metastatic patient hormone sensitive is a synchronous versus metachronous. whether you are dealing with a high volume versus a low volume, whether you are dealing with a oligometastatic versus a florid metastatic. So 10 to 15% of these patients will have a BRCA2. So whether your patient is a BRCA2 carrier, a mutant, or non-BRCA, or still ADT alone as a singlet versus doublet and triplet. So these 5 points becomes important when you are moving into a new NCCN. So as you saw that 2023 and now 2026, this included 5 of this. So now you see 2026. So 1 page of NCCN to now it has been made to two pages. So here highlighted is a hormone sensitive prostate cancer, metastatic hormone sensitive prostate, but high volume. So if your patient qualifies for a high volume metastatic hormone sensitive prostate, then synchronous and metachronous will be treated with, you can see, so where the preferred treatment was abiraterone, enzalutamide, and apalutamide here. So now triplet becomes the first choice, ADT with docetaxel, either with abiraterone or dilutamide. Second is, if the patient is not fit for a triplet, then ADT with abiraterone, apalutamide, and enzalutamide. And now, as other recommended, is a dilutamide. And if you see the third point, even in a first line setting, ADT, if the patient is a BRCA2 mutant, then this patient will be a candidate for a niraparib with an abiraterone. So that is a gross change from 2023-26. Moving on to the second part. So this is a low volume or an oligometastatic. So if it is a low volume disease or a oligometastatic disease, so you have a choice of, again, it is similar to what you saw in 2023. So you treat with ADT and abiraterone, you treat with apalutamide, enzalutamide, or dilutamide. And with combination, so you will avoid using triplet in a low volume, because you can see the NCCN says category 2B for a low volume metastatic disease. The second is a metachronous but low volume metastatic, where again ADT, so with single abiraterone, apalutamide, or enzalutamide. And again, for a BRCA2, it is niraparib and abiraterone. So that is, so moving from 2023 to 26, so you have to have these 5 caveats for synchronous versus metachronous, high volume, low volume, oligofluorid, and BRCA2 versus non-BRCA, and singlet, doublet, and triplet. So now factors to consider before selecting any of these ARPI. So now you have 4 drugs in hand, oral drugs. So you look at a progression-free survival. So in prostate cancer, usually progression-free survival is a radiological PFS, then overall survival, then quality of life, which has taken into an account even in the dilutamide studies, safety and tolerability. So it includes the patient's comorbidities, and ultimately time to castration resistance, where the patient moves into a next line of treatment. So now, so I have eased out for you. So the pivotal trial, clinical trials for dilutamide. So Aramis, so all starting with A, Aramis, Arasens, Arasec, and Aronet. So AR, so all. So Aramis was the first trial, which is a phase 3 trial. So this was in a non-metastatic HRPC, where ADT plus or dilutamide was used. Then came Arasens, which was again a phase 3 trial. In a next 3 are all metastatic hormone sensitive prostate. It was a triplet, ADT plus docetaxel plus dilutamide. Arasec was only the phase 2 trial in a metastatic hormone sensitive prostate where used ADT plus dilutamide. That actually helped us to go into an Aronet, which was phase 3, and which my center and I was a part of that Aronet. So which we'll be discussing again in the metastatic hormone sensitive prostate cancer doublet, that is ADT plus Daro. So different between an Arasec and Aronet, it was a phase 2 and it is a phase 3 trial. So for a pivotal clinical trials, so dilutamide, we need to know these are 4 trials. So we'll discussing the ARONET trial. So there is an unmet therapeutic need for this group of patients. So moving from Arasens to an ARONET. So we knew that a darolutamide and ADT and docetaxel triplet, but triplet is not everybody's choice because of toxicities, and so then it needed a design so where chemotherapy can be omitted for those group of patients who are not fit, and that is how the ARONET developed. So before ARONET, it was an Arasent. So this got a publication that ARONET, which was a phase 3 trial of metastatic hormone-sensitive prostate cancer, absolutely untreated patients or who has progressed from either a de novo metastatic or who has progressed after an adjuvant therapies. And these got published in 2024 JCO. And so this was basically a double-blind study. And so this was around 700 patients, 665 patients, metastatic hormone-sensitive prostate cancer, histologically or cytologically confirmed adenocarcinoma prostate, some PS0, even PS2 are included. So normally you don't include PS2 in many other solid tumors, but prostate cancer is totally a different ballgame. The stratification factors were visceral metastasis, absent or present, and prior local therapy in the form of radiation, yes or no. So the randomization was 2:1, and we know the darolutamide dosing is 600 milligram twice daily with ADT. So here ADT was Goserelin 10.8 every 3 monthly, and the standard arm was placebo plus ADT. So there were many critics for this trial when this trial came to India. So many of the PI said that so placebo and ADT cannot be a standard arm because this is a weaker arm. So there were lots of critics. And this trial had a primary endpoint, which was radiological PFS, and there were n number of secondary endpoints, including the quality of life. So the data cutoff was from June 7 to 2024, and selected endpoints were OS and safety. So if you see the patient characteristics, these were well balanced, and almost 1/3 of patients were Asians. And if you see performance status 1 and 2, means symptomatic patients were almost 50% patients. And de novo metastatic were more, that is almost 2/3 of the patients. And recurrent disease were almost 1/3 of the patients. Now here it is important to see that disease volume in terms of high were almost 2/3 of the patients. And visceral metastases were low, actually less, where skeletal metastases predominantly were more than 80% of the patients. So less number of patients had actually a visceral disease. And if you see 20% of the patients had some form of local therapies. So these are important as we go on. And if you see the Gleason score more than equal to 8, were almost in 70% of the patients. And you'll be amazed to see that the serum PSA, the median PSA were only 21.4. If you see the ranges, it was up to 15,000, but the median PSA was something around 21.4 in both the arms. So these were the country representations for this trial. And if you see the ARONET, as I said, India had 93 patients. So 61, because it was 2:1. So 61 patients in the darolutamide arm and 32 patients in the placebo arm. So we had 5 patients from our center at Sparsh. So out of 5, 1 had a screen fail. Out of 4, so these 4 patients were randomized. So after the blinding was over, then we could know that out of these 4 patients, 3 were in the darolutamide arm and 1 patient was actually in the placebo arm. And out of these 3 patients in the darolutamide arm, so the last patient has almost completed 4 years now. So this June 2026, this patient will complete 4 years since we have started the treatment, and rest 2 patients have progressed. So out of 4 patients, as I said, so 1 was in the placebo arm, 3 were in the darolutamide arm, and out of these 3, the last patient was enrolled has almost touching 4 years since we started the treatment in June 2022. So now looking at the first primary endpoint, which was a radiological PFS, and which was the primary endpoint. So it was almost 46% decrease in death in the darolutamide arm, 70 versus 52%. And the median follow-up in the darolutamide group was over 2 years. And if you see the benefit of darolutamide across all these subsets, if you see this, so disease volume. So though, as I said, so very few patients will have a high volume disease here. So if you see a low volume disease had a hazard ratio of 0.30 as compared to high volume 0.60. So it means low volume disease has really done well. Second, we'll see visceral disease. Again, less patients were in the visceral disease. Again, if you see, so patients who did not have a visceral disease had a hazards of 0.52 versus patient who has a visceral disease of 0.71. But again, you cannot comment because there were less than 20% patients in the visceral group. Third point to note here is the local treatment, which was only less than 15% of the patients received. Again, those patients who received local therapy had a hazards of 0.34 versus 0.59. So the importance is that all patients benefited. The quantum of benefit in the low volume, the quantum of benefit in the patients who did not have a visceral metastasis, the quantum of benefit who received local therapy were significant in terms of HR value. So darolutamide plus ADT demonstrated benefit across all secondary endpoints. So that was a primary endpoint of radiographic progression-free survival. So time to metastatic CRPC, time to PSA progression, and time to initiation of subsequent systemic therapy for prostate cancer, which you can see all the diamonds are in the favor of darolutamide, especially a time to PSA progression. So another important in this ARROWNET study was time to pain progression, which was not there as an endpoint in any of the other ARPI. So here you can see, so that was also in favor of darolutamide. So at the time of primary analysis in 2024, OS data are immature. Since OS is immature, patients will be followed up for survival. As my patient is almost on a 4th year now, so this patient is being followed up. So time to CRPC, metastatic CRPC, as already alluded to. So you can see it is favoring darolutamide where it is not reached versus in the placebo arm 13.8 months with the hazards of 0.40. Time to pain progression, as I said, which was typical of this ARROWNET study, which was not there for other ARPI. So again, hazards of 0.72. So favoring darolutamide arm where it is not reached versus 29.9 months in the placebo. So delay in time to pain progression can be of high importance to patients and have not been demonstrated with other ARPI till date. So darolutamide plus ADT achieved a deep and a durable PSA response. So PSA less than 0.2 nanogram per ml at any during point. So 62.6% in the darolutamide versus 18.5 in the placebo arm. If you see the time to PSA progression, darolutamide versus the placebo was hazard ratio of 0.31. So normally such type of hazard ratio we have seen in metastatic breast cancer where in a metastatic hormone positive where we have used the CDK4/6. So 63% of patients in the darolutamide doublet arm attained a PSA of less than 0.2, and these representations are almost 70% improvement in time to PSA progression in the darolutamide arm versus the placebo arm. So be it in high volume or a low volume, so this PSA of less than 0.2 was seen at different intervals, 24, 36, 48 weeks at any time, both in favoring favoring the darolutamide arm in high volume and low volume disease. So time to second therapy on progression. So you can see it was 70% plus in the placebo arm. So more patients require subsequent therapies, whereas less patient in the darolutamide arm. And obviously, these patients did not receive chemotherapy. That's why the first on progression, the therapy was docetaxel was almost in 1/4 of the patients in both the groups. Now coming to toxicities, so of the treatment emergence adverse events were similar between the treatment groups. So these drugs did not add to toxicity except some amount of fatigue. Continuations were lower in the dalatumab arm. So if you see the even grade 3 and grade 4 or grade 5 were not significant, not even the serious adverse events. If you see the discontinuation rate, surprisingly was less in the dalatumab arm, 6% versus 9% in the placebo. Median treatment duration was almost 24 months in the daro arm versus 17.3. The safety profile, as I said, was almost similar to what we have seen in the Aramis and the Aracins. Most common other toxicities, so be it a hematological and non-hematological toxicity remains the same, except some amount of increased fatigue. We have seen this across all TKIs and newer drugs. Some sort of, so many a times it is very difficult to manage because none of these drugs, so probably some sort of behavioral therapies and some sort of yoga pranayam might help to overcome this fatigue. And these are different toxicities with ARPIs, which was seen with dalatumab and placebo. If you see, starting from all hematological and non-hematological toxicities, so this has remained the same for both. So this drug has not added toxicities, as I said, in a significant amount. So now dalatumab confers a positive impact on health-related quality of. So you know that. So once you are using a new drug today, since last few years, so this becomes an important. So ASCO 2025 last year, so dalatumab extended a median time to deterioration in the FACT-P total, because these are all elderly gentlemen patients. So where definitely this makes more sense. So total score by 5.1 months versus placebo, and this is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression and overall well-being, and that has been shown in the slide on the right hand side. So dalatumab AD median 16.6 months, 6 months versus 11.5 months in terms of deterioration of the patient's well-being, that is FACT-P total score. So what has, if you see, so what are the aspects of the FACT-P subscore that has favored the dalatumab arm? So it is deterioration of overall well-being, especially on a social, functional, and urine symptom domain, which is important for any prostate cancer clinical trial. And you can see, so this favors the dalatumab arm that in the ARONET. To conclude, so dalatumab, which is one of the new ARPIs out of the series, plus ADT significantly improved the radiological PFS in patients with metastatic hormone-sensitive prostate cancer, especially for those patients who are not fit for chemotherapy. So dalatumab showed a benefit across all secondary endpoints, which I have already shown you in the slides. Dalatumab was associated with deep PSA response regardless of a baseline PSA. And dalatumab is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression. And the FACT-P scores like social and family well-being, functional well-being, and urinary symptoms were also better as compared to placebo. So dalatumab had a favorable safety profile. So does dalatumab plus ADT without docetaxel, which was the result of an ARONET study, is an additional standard of care for a metastatic hormone-sensitive prostate cancer. So thank you, friends, for a patient hearing. So I'll be happy to answer you any of the questions. Thank you
Thank
so
you,
much.
sir.
Thank you, sir. Thank you very much. Thank you for
Thank
your
you, sir.
nice presentation, sir. We're going to the next session with the permission of
Please.
Dr. Ghanashyam, sir. Sir, can you proceed, sir, for the next topic, sir? Yeah, thank you. Thank you, sir. For our next session, we are going to invite Dr. Rajiv Lochan Jena, sir, who is a consultant medical oncologist at NCRI Hospital, Kolkata. And his session is on reaching new heights in the MHSVC care. So we are going to welcome Dr. Rajiv, sir. Welcome, sir.
Good evening. Good evening, everyone. Good evening,
Good
sir.
evening.
So I am sharing the slide from my end.
Okay, okay, sir.
Okay. So I will be discussing about, is it visible?
Yes, sir. Audible and visible both.
Okay. So I'll be
Thank you, sir.
discussing about reaching new heights in metastatic hormone sensitive prostate cancer care. So this is my disclosure. And the prostate cancer landscape, as sir has very beautifully explained, that we can have a newly diagnosed metastatic hormone sensitive prostate cancer, or we can have a primary progressive metastatic HSPC or non-metastatic CRPC. Whatever it be, the final endpoint is metastatic CRPC. And so we can see, just wait 1 minute. Can I ask that tech support to share the screen from your side?
Yes, sir.
Actually,
Yeah,
yeah,
I'm sharing. Sagnik, sir. I'm
okay.
sharing from my side, sir.
Okay.
You just close on. I'm sharing.
Okay. Actually, most of the some part of the slide is not visible to me because
Yeah, maybe sir. It's a technical problem.
uh,
No issue,
uh,
sir.
okay.
Hope my screen is visible, sir.
Yes.
Just give me 1 minute.
Okay.
Okay, sir.
Yes. Yes, next slide. Yeah, next slide.
Yes, just one.
Yeah. So patients who suffer. Yeah. Okay. So metastatic CRPC is the thing we wish to avoid in our patients, because this is the end disease from where patient goes on to terminal disease. So patients who suffer and die of prostate cancer all have CRPC, and it has been seen that treatment of metastatic CRPC, the OS improvement of only 2.5 to 4.5 months is seen. So next slide.
Just one.
Okay, so this makes metastatic HSPC our biggest opportunity of delaying deaths from prostate cancer. So delaying progression to the lethal form of prostate cancer strongly would improve outcomes. So coming to the next slide, it is the STAMPEDE control arm where ADT was only used, and we can see failure-free survival and overall survival rates here in the curves, Kaplan-Meier curve. We can see that the failures, the proportion, if we see the failures, almost 50%, that is the median failure, it was around 11.2 months, while 50% of the patients died in the first 3.5 years. So, the next slide.
Yes, sir.
So there is much chance of improvement here. Next slide. So in the STAMPEDE trial, we can see that it defined the role of radiotherapy, and especially we can see in less than 4 bone mets, we can see the failure-free survival and OS between the two arms, that is standard of care treatment versus standard of care treatment plus RT. We can see RT had a role in less than 4 bone mets, while it was of not much significance when it was more than equal to 4 bone mets. Next slide. So now the improving outcomes with systemic therapy. Moving forward, as sir has already explained, over the years, where docetaxel first came in around in the 2013, 2015, and after that we had the Stampede and Latitude trial where abiraterone came in. Then we have Archies for enzalutamide, Titan trial for apalutamide, Enjamid for enzalutamide, and then we had the Peace One trial where abiraterone versus standard of care, and later on docetaxel was added as the standard of care changed with time. There also we found a hazard ratio of 0.75, and recently we have the Arasens trial where darolutamide plus docetaxel versus docetaxel. It came in 2022 with a very good hazard ratio of 0.68. So now we have a plethora of options. Now so we have a wealth of data, but what we choose, we have to decide. Next slide. Now, from the charted trial, we can see that docetaxel in metastatic hormone-sensitive prostate cancer, we could very well see that in the high volume diseases, in the charted trial, high volume diseases, it included any patient who had a visceral mets or more than equal to 4 bony mets, of them greater than equal to 1 bony mets, not in the not only in the axial skeleton. And there we can find that here the hazard ratio was 0.63 favoring the docetaxel plus ADT arm with a p-value quite significant. The improvement in OS was 16.8 months, but this did not hold good for low volume disease where the hazard ratio is 1.04 and a p-value of 0.86. Next slide. Now the Latitude trial where the role of abiraterone came in. Here we can see in abiraterone in high-risk metastatic hormone-sensitive prostate cancer. Abiraterone was the first to show that hormonal treatment can be effective. However, it is important to understand the treatment journey of the control arm when interpreting this data. Here we can see that PSA progression, if we see between the two arms, here for placebo plus ADT, the PSA progression, it was median PSA progression was 7.4 months. While the subsequent prostate cancer therapy, the median months, it is 21.2 months. So there was a delay in treatment initiation in most of the cases. So there was a scope of improvement there. Next slide. And considerations for abiraterone used in metastatic hormone-sensitive prostate cancer, even if only 5 mg prednisolone is given in metastatic hormone-sensitive prostate cancer, we could see that hypertension, grade 3, grade 4, it was seen in 22% of the patients in the ADT plus abiraterone plus prednisolone versus the ADT plus placebo where it was 10%. Hepatotoxicity was also higher with ADT plus abiraterone plus prednisolone, and the most important hypokalemia, it was also grade 3, grade 4 side effect. It was 11% in ADT plus abiraterone. Next slide. We had the Titan trial, which established the role of apalutamide in metastatic hormone-sensitive prostate cancer, where we can see the PFS, the hazard ratio was 0.48. That is almost a 50% reduction in risk of progression. And we can see overall survival, the hazard ratio was 0.65, which was around a 35% reduction in the risk of death. And here we can see from the subgroup analysis that low volume and high volume both fared very well. So the improvement was seen both in low volume and high volume disease, which was not earlier seen in case of docetaxel. Next slide. Now coming to the next trial, Enjamet, that is which established enzalutamide in metastatic hormone sensitive prostate cancer. Similarly, the hazard ratio here was 0.4 for clinical progression free survival, and overall survival it was 0.67. And if we see the low volume and high volume disease, we can see for low volume disease the hazard ratio was 0.43 with a p-value which was significant, and for high volume disease it was 0.8. The p-value is 0.14, which was not very significant. Next slide. Now coming to the combination therapies to further improve outcome, which sir has already told. First came the era of single agent, then double agent, and now we are moving towards triple agent therapy right now. Next slide. So this is the PEACE-1 study design, where it included de novo M1 disease, and we can see it was randomized into 4 arms. One arm B, it was standard of care treatment plus abiraterone plus prednisolone. And later on, we can say that this standard of care treatment, initially it was abiraterone, while later on, during the progression of the trial, docetaxel was also added to ADT, which became the standard of care later. Next slide. So the trial was not designed to see whether a doublet or triplet was better, but we have data to see the responses. So here in PEACE-1 trial, ADT, docetaxel plus minus abiraterone. So for high volume and low volume disease, we can see that for high volume disease, the hazard ratio, it was 0.72 with a p-value of 0.019. While for low volume disease, the hazard ratio was 0.83, but the p-value was not significant. So it was, so the addition of, so in the triplet regimen, it was of significance in the high volume disease only. Next slide. Now coming to the ARASENS trial, which is a global randomized double-blind placebo-controlled phase 3 trial, where metastatic hormone-sensitive prostate cancer patients were included, and they were randomized into 2 arms, docetaxel plus darolutamide plus ADT versus placebo plus ADT plus docetaxel. So docetaxel was common to both the arms, and 6 cycles of docetaxel were planned. And here the endpoints were OS, primary endpoint, and there were many secondary endpoints, some being time to castration-resistant prostate cancer, time to pain progression, symptomatic skeletal event-free survivals, etc. Next slide. So the ARASENS trial, the overall survival, if we see for overall population, we can see the hazard ratio was 0.68. The median, it was 48.9 months for placebo versus for darolutamide, it has not reached. And we can see that at 51 months, 63% of patients who were on darolutamide are still alive, and it was 50% in case of placebo. Next slide. Now coming to the high risk and low risk patients, as we saw in PEACE-1 trial, it was only beneficial for high risk patients. Here, the benefit was seen both in high risk and low risk patients with hazard ratios of 0.71 and 0.62 respectively. So it shows benefits both in high risk and low risk patients. Next slide. These are the secondary endpoints, the time to CRPC, where we can see a 64% risk reduction, time to first subsequent anti-neoplastic therapy, a 61% risk reduction, even time to pain progression, and time to first symptomatic skeletal event. In all, we can see around means risk reductions. Next slide. Now the Arasen's PSA response and outcome, here we can see that irrespective of the time, we can see around 67.3% patients had undetectable PSA in the darolutamide plus ADT with docetaxel arm versus 28.6% in the placebo plus ADT with docetaxel arm. And respectively for 24 weeks, 26 weeks, and 52 weeks, throughout it maintained the difference, and the undetectable PSA rates were quite higher. Next slide. Similarly, the time to PSA progression, we can see the difference. And for overall survival also, it was seen that patients who had an undetectable PSA at 36 weeks versus patients who had PSA detectable at 32 weeks, the median overall survival was not reached in the undetectable arm versus 33.3 months in the detectable PSA at 36 weeks, with a hazard ratio of 0.37, which was very significant improvement. So more than 2/3 of patients, as we know in this trial, they reached PSA of below 0.2 in the overall study. Next slide. So coming to the PSA response and outcome in high volume HSPC, we can see at any time around 62.2% of patients had undetectable PSA, which is a very good number considering the high volume disease. Next slide. So similar, next slide. So similarly, we can see like as we saw in the overall population for high volume disease also, darolutamide, when we compared for overall survival, if we compare darolutamide, the darolutamide arm versus placebo arm, the median survival was not reached versus 22.1 months. So darolutamide triplet achieved long periods of no disease progression and also significant improvements to overall survival. Next slide. Now coming to the low volume metastatic HSPC, this is the subset which was most benefited, with around 83.8% of the patients who had an lifetime undetectable PSA. And we can see if the overall survival, if we see both the medians for both the arms have not been reached, but we can see the hazard ratio so far is 0.34, which is almost a 65% reduction in the risk of death when an undetectable PSA was achieved in a low volume subset. Next slide. So now the question is about deciding between doublet and triplet in metastatic HSPC. The things we have to consider are patient, whether they are able to tolerate and accept docetaxel, because that is the first criteria which a patient has to fulfill to take a triplet therapy. Then the extent of disease, whether it is a high volume disease or a low volume disease, whether it is a high risk disease or a low risk disease, likelihood of hormone insensitive clones, the age and life expectancy, hit hard and early, because prostate cancer will be the cause of death. Next question is, will docetaxel be an obligation in the near future, much less effective post ARPI progression? And patient needs to be informed of the options. So these are the questions for which we will be more clear in the future. Next slide. So this is my final slide, where we can say that comparing the PEACE-1 and Arasen's trial, what we can see that the Arasen's trial, means it was beneficial in both low volume as well as high volume disease. So this is a good sign, and we can use it in our patients for their benefit. Thank you.
Thank you, sir. Thanks for your nice presentation, and thanks to our previous speaker and also Rajiv sir. We're going to the next session with all your permission of our previous speaker. So we are going forward to our next session with Dr. Santosh sir, who is from Senior Consultant Medical Oncology from Star Hospital, Hyderabad. So I'm going to invite Dr. Santosh sir for his case presentation. Welcome, sir.
Thank you. Thank you. Good evening, everyone. After two fantastic talks from Gansham sir and Dr. Rajiv Jaina sir, so basically, uh, I want to make the presentation a bit interesting using of AI I have used in preparing few of the slides. So the main thing is how do we do in a practical way the data we have seen. So I have a real world case we would discuss in it. So how we have translated the information from the clinical trials in the real world practice. So here is my case. A 76-year-old male, he presented with heavy hematuria. That was his initial presentation. He denies previous any pain or any other problem in the past. So on evaluation, we found to have high volume metastatic castration sensitive prostate cancer with a high risk disease, Gleason of 3+4 of 7. The PSA astonishingly was very high with 36,500. There was no visceral disease. There was extensive bone involvement. There was large mass that is arising from the prostate extending to the base of the bladder, causing heavy hematuria. The other thing is he was frail in this scenario, and he has a comorbidities of hypertension, coronary artery disease, and hyperlipidemia. So this is the highest amount of PSA that I have seen in my limited experience. I would ask Senior Dr. Gansham sir, what is the highest? As in the trial, you have mentioned the range of 15,000 to as low. Also, the median was 15. Sir, in your real world, what is your highest value of PSA that you have seen, sir?
Because most of the time, if it is more than 1,000 or 5,000, so most of the lab doesn't report.
Yes,
So
yes.
more than 5,000, I've seen quite a few. More than thousands, quite a lot I've seen. But absolute value beyond that, most of the lab they ask for that even after 2 dilution, 3 dilution. So probably that may not be feasible. So that's why absolute value many a times, unless and until you chase that, you won't get it. So clinical trial scenario was different because these samples were going to the central lab, so that's why they were giving the absolute value. Otherwise, in clinical, so more than 1,000, unless and until you ask for a dilution, so they don't give, and beyond 5,000, it is written as more than 5,000.
Yes, sir. Point rightly put forward, sir. In this case, the report that we have got is more than 1,000, more than 5,000. So I asked the lab specifically, sir, I need a particular value so that I can follow up. So they have done 10 serial dilution, after which we have done this value. So we have also reconfirmed other lab also. So this was 36,500. Possibly we miss a lot of cases where labs just report more than 5,000 and more than 1,000 as elucidated by Gansham sir. So tech team, can you help me? My screen apparently is frozen.
Yes, sir. What happened?
Uh, Basically, I'm unable to advance my slides forward. Is there anything?
Sometimes you click on the slide. You click on the slide and just move.
So just click on slide.
Right.
Yes. Right. So what I did is I have done a next generation sequencing for possible finding of BRCA2 or any other thing so that we can offer an additional target in this patient. So what I have found in this scenario is we have a report which has an alteration known KDM6A along with ASXL2 and MLH1. So this KDM6A is reported in prostate cancer, which possibly is one of the high risk factor in prostate cancer. At this age, we also have some chip mutations also. We should be very careful in integration. So we do not have a HRR mutation that possibly I was expecting or hoping. to add an additional treatment option in our patient. So this is what it is. We have a sky high level of PSA, very, very high. The burden of disease is very high. There is a large bladder mass that is causing heavy hematuria, bone metastasis, both axial and extraaxial, with a high volume, high risk at one side. And at the flip side, the patient is frail, having a comorbidities of coronary artery disease, hypertension, hyperlipidemia, using a lot of medications. He's frail. Social support is limited. So we have a area where we need to have an early response. At the same time, we should not have side effects. The patient is a very, very learned gentleman. He was very clear in what he wants and what he doesn't want. So he told me, sir, I need a medication that has very minimal side effects. I need no chemotherapy, and I need early response of hematuria. So this is what he told me. And the social support was also not great. The son and daughter stays abroad, caretaker would be there. They come and see once in a while. So this was the social support that we see in elderly gentlemen. So he's not fit for chemotherapy, very high volume of disease. We need early response and early control of hematuria. And he's not fit for chemotherapy. His frailty and geriatric comorbidity index is high. And there is risk of fall because of his elderly age. So these are all the few important things that we take into consideration when we take a decision. Suppose in this case, if we see elderly patient, frailty, performance of 2, not fit for chemotherapy, so docetaxel is out, so I cannot give a triplet, so I have to use 2 agents, that is a doublet, very high volume of disease, need an early response and control of hematuria, no HRR related alterations. So I possibly thought of adding a third agent using this one, where we have emerging data with using of this. And patient is have polypharmacy. We know a lot of drug interactions, and he has coronary artery disease, and also so using of steroids along with abiraterone is an issue. And there is risk of fall. Some of the agents that we use, especially enzalutamide, apalutamide, have some risk of falls. So these are the prerequisites before choosing a proper appropriate regimen in our case, where there are a lot of coexisting factors. So also the patient is very, very well read. So he has himself, even though old, is a very learned gentleman. So these were the prerequisites and the thought process that went in my mind. So in this scenario, with the baseline in July 2025 with a high value of PSA, I've started him on all oral regimen with relugolix and darolutamide. This is what I have started in July. In 15 to 20 days, he have good improvement of symptoms and sense of well-being has improved. He's able to move around, walk around. Hematuria was controlled. We have had a backup option of hemostatic RT once the hematuria doesn't control. Luckily, the hematuria controlled and he did not require any blood transfusion. So this was the initial PSA that we have started. He complained of mild fatigue in the 2nd and 3rd month, but after having ginger, lemon and all, he recovered. In September 2025, the subsequent PSA value shows tremendous reduction with a value of 10.8. Subsequently, in December, there was still steep decline with a value of 0.47. Currently, in the month of March, we have decided and it has achieved a very, very, very low value. So as we have seen in talk of Dr. Ghanshyam sir and also Dr. Rajiv Jaina, where if there is undetectable PSA achieved at any point of time, that is less than 0.2, it portends good long-term outcomes, where we have seen an impressive hazard ratio of 0.23 and 0.31, 0.23 in case of Aranode trial and 0.3 in case of Arescens trial. Possibly with this value of PSA, I am expecting a good long-term outcome. As one of the patient of Ghanshyam sir has 4 years from the trial he is continuing. I hope this our gentleman also has good this, fingers crossed. Patient is very happy, limited side effects, all oral medications, limited interactions, able to manage everything independently with intermittent social support. So this is my experience in this case that I had. This is the thing that I wanted to discuss, where a patient who have undetectable, although this is in relation to Addison's trial, undetectable PSA less than 0.2, we have almost flattening of the overall survival. So this is my limited experience of using darolutamide in one of the case. So I would invite comments from Dr. Ghanshyam sir and Dr. Rajiv sir regarding what different you could have managed this case, or how should we do it further. Sir, your points,
So
please.
I think Santosh, so you have done a great job for this patient. But in the Arasens trial, it was a GnRH analog goserelin, so they haven't used the antagonist. But in reality, so probably this is the right candidate where you are going to use antagonist. So be it a degarelix or an relix, being one of them is an high, such a high PSA, such a axial involvement, probably that can lead to a compression or a spinal cord compression. And thirdly, the patient had a coronary artery disease. So these are right indications where you'll still prefer an antagonist, so be it a degarelix and a relugolix. Second thing, since this patient had a bladder mass, hematuria, so probably I had upfront given a hemostatic RT of 1 or 2 or 5 fractions. So probably because, so you were lucky that the patient responded and you could wait, because this hematuria can bring the patient off and on to the hospital and get it flushed. Then you have 5 liters of saline, 10 liters of saline, because clot will be a problem. And once there is a clot, the patient goes on into a dysuria, a burning sensation. So this is a problem for these elderly patients. So I would have probably start with an hemostatic RT. So maybe otherwise the rest of the things so you have done was absolutely fantastic. If the patient probably wouldn't have afforded for a darolutamide, because there are patients in a government scheme, so probably I would have started because of frailty. So you get it done the G8 score, so it will definitely be more than 12. So probably I would have opted for a low dose 250 milligram of abiraterone with the protocol that has even Dr. Senthil has published from India. So probably so antagonist and a low dose of abiraterone in a patient who is not affording for darolutamide. Otherwise, you have beautifully managed the patient and you have got the result. You rightly said, if you have achieved less than 0.2, so this patient might be a long-term disease control. So finger crossed. So coronary artery disease. So the patient can be killed by not prostate cancer, but probably other competitive diseases.
Thank you for your views, sir. Rajiv sir, your views, anything?
Yeah, I agree with sir. So it was well managed. If hematuria would have worsened, of course, radiation would have been means we could have taken the help of our radiation oncologist colleague. But in your case, it means the patient responded very well, and hematuria was means it was controlled. And one more thing, as sir told, like finance is an issue in patients who would not be able to afford a darolutamide. Maybe the other triplet regimen, where in elderly patient maybe a abiraterone at low dose. But of course, coronary artery disease is present in this patient. Darolutamide would have been my choice too.
Thank you, sir. Thank you,
So
sir.
Abhinav, I want to leave actually. So I told you, no?
Yes, sir.
Yeah, wait. No issue, no
So,
issue, sir.
sorry, Santosh and Rajiv, you can continue discussion.
Yes,
So
sir. Thank you, sir. Thank you, sir.
Welcome, sir. Thank you for being here and nice presentation, sir.
And Santosh, it was it means the use of AI was very nice. Your slides were well prepared.
Okay, thank you. Thank you very much, sir. Thank you.
Yes, thank you.
That's it from my side. Over to
Yeah,
Bayer.
thank you, sir. Thank you, Santosh, sir. And fantastic presentation and nice ways, because presentation and nice discussion, sir, after all. So I think that there is no such questions or anything, something. So with your all permissions, we are going to conclude the session. And thanks to all our speaker. Thank you, Rajiv, sir. Thank you, sir. Thanks for being
Thank
here.
Good night. Good night.
Good night.
Thank you. Thank you.
Thank you. Yeah, we